So then we can switch back to the original order. I just saw that Piero is online. Again, it's my pleasure to introduce Piero Fossati, the head of the carbon program in MedAustron. Piero, it's all yours.
Okay. So apologies, we had a little bit of an issue with time zones, and I didn't realize that it's 1 hour later in Greece than here. So that means I'm collecting Leighton from my car, but hopefully it should work. And that was the first apology. The second apology, because of organizational issues, we are now having this talk, which is not really fitting very well in the pediatric session. It's more the general carbon ion approach for MedAustron, and there is just a little bit of pediatric at the end, but you will hear about our pediatric approach in Wiener Neustadt from Carola in a very short while. So as you know, we have proton and carbon. So how do we decide when we should use carbon? And we have basically three pillars of this. Of course, radioresistant histology, tumors in which we are not happy with the local control that we can achieve with other treatment techniques. And the second one would be not the histology, but the behavior of the tumor. So we have a lot of re-irradiation, and we not only use carbon ion when we have a re-irradiation of sarcoma or salivary gland or such radioresistant tumor, but also when we have a tumor that in the first diagnosis was maybe considered not radioresistant, but then proved itself to be worse than we could think. So an early in-field recurrence after adequate dose is a tumor that has been selected for radioresistance, and it is also where we consider carbon ion radiotherapy. And then the physical difference, carbon has the fragmentation tail, so that's worse than proton, but it is sharper, so smaller spot and sharper penumbra, that's better than proton. And I will show you that this is not really very, very often so relevant that makes the decision. So let's start with radioresistant histology. Of course, the bulk of our carbon ion program is about sarcoma and non-squamous cellular head and neck cancer. And then we are also treating some high-risk prostate cancer, some local recurrence of rectal adenocarcinoma, and so far kidney cancer, which for sure is a radioresistant disease, has been not really part of our clinical routine, but is just a program for the future. So head and neck, just to give you a little bit the workflow of what we do in MedAustron. If the patient comes to us, first question for a head and neck non-salivary gland to ask is there macroscopic disease? If no, if it was just an R1 resection or even R0 resection, but with risk factors, also if the patient purely needs post-operative treatment, then we are happy to treat the patient, but we treat it with proton therapy. Instead, if there is macroscopic disease, then carbon comes into play. And then the next question is, how big is the macroscopic residual disease? So if we have this bulky tumor with not a very high tendency for lymphatic spread, let's say, for example, a adenoid cystic carcinoma or the maxillary sinus that has grown with perineural infiltration toward the skull base, negative lymph nodes, we don't treat the nodes in those patients, and then we treat with carbon ion, hypofractionated 16 fractions, reproducing the Japanese protocol, so what we call near style. Instead, suppose that we have a tumor in which the surgeon did a very large resection, maybe even with a flap, maybe even a tumor that has a higher tendency to spread through lymph nodes. So we have to treat a large volume, which is just a volume at risk without macroscopic disease. And on top of that, we have maybe an overlooked macroscopic tumor in the sinus cavernosus, which very often is the case. They say, I did an R0 resection, except that no one had diagnosed in the first place that the macroscopic disease in the cavernous sinus. So in those cases, we follow the German approach, the so-called HIT style. We treat with low LET radiation, the big volume, and we give just a carbon boost. And then there is a third group of patients in which we are developing a sort of Austrian style. So it is in patients in which there is a bulky tumor, and we are afraid that only carbon boost might not be enough, but also we are afraid that we cannot skip the elective node irradiation, as is the standard practice in Japan. So this is an example of a patient treated with a Japanese approach. you see a bulky disease. It was adenoid cystic carcinoma infiltrating the skull base. We thought that this disease was at very high risk of perineural spread, but not at very high risk of lymphatic spread because of the histology, because of the primary site, and because of the good results reported by Japanese colleagues, even when skipping the elective node irradiation. So this patient we treated with 16 fraction, 4.3 gray times 7 for the PTV. But we lowered a bit the dose because we were afraid of long-term toxicity for the PTV1. So this is how we use carbon ion in patient with bulky tumor, in which we basically focus on the tumor, and you can see some contrast enhancement in the temporal lobe, which remained asymptomatic, and you can see the very nice response. Then we have the other approach that I was describing to you. So bulky macroscopic disease in which the surgeon goes in, and then there is a very large post-surgical cavity. So this is only post-surgical. It is at risk of toxicity if we treat all with carbon. But in the very first place, there was already macroscopic tumor along the nerves. This was overlooked. It's unfortunately relatively often that we see such a situation. So we say, well, we don't purely treat protons post-op because there is some macroscopic disease. And this is an example of what we treat with the German approach. So just 50 gray of protons or photons according to the availability, etc. And then we just give the boost 24 gray in fraction of 3 to the macroscopic disease. And then there is our attempt to try to get a little bit a compromise in some patients. Here you see a case in which we had a very no, sorry. This is the plan that I was describing to you. So this is the proton for the large post-op cavity and just carbon boost. As said, 50 gray of protons for the post-op cavity where we are afraid that carbon might be too toxic, and carbon boost for the macroscopic residual disease in the Meckel cave. But then it has been for a long time in the past like a soccer competition, Germany versus Japan. Always treat the lymph node, never treat the lymph node. And then, of course, this is not the right spirit. And then we all agree with our colleagues in Heidelberg, with our colleagues in Chiba, that there are a lot of gray zones in which we have to find a compromise between the two approaches. And this is what we are doing now. And this compromise is patients in which there is bulky disease. Oh, I don't know why there is here. There was also some voice, but that was not my voice. So here we have this mixed approach in which we try to put more carbon ion dose. So here you see bulky disease that was in the skull base with macroscopic infiltration of the nerves, but also because of the bulky adenoid cystic of the base of tongue, we said we cannot possibly skip the bilateral node irradiation. And we were afraid to treat all this big volume with carbon, but we were also afraid to give only a boost to this bulky disease. So what we are doing in this patient, we are treating the big volumes with half carbon, half protons, 30 gray of protons and 18 gray of carbons in fraction of 3. And this is done in our prospective registry trial. So that we have something which is intermediate between the German approach, boost only, and the Japanese approach, all with carbon, and we can extend the volumes without toxicity. This is a relatively new protocol, and we have accrued only 4 patients, so the results are pending. It's just to show you our approach. Now, the other big topic that we treat with carbon is sarcoma, and we will use sarcoma to also show you how we are using carbon. The peculiarity of MedAustron is that we are trying really to have plans that look acceptable not only with one RBE system, but with both RBE systems. Our plans are planned, optimized, and reported with the local effect 1 model. So like in Heidelberg, like in Knau, like in Marburg, like in Shanghai, but we are always recomputing the plan with the alternative MKM model, so the one used in all the Japanese centers, and we are trying to achieve target coverage and organ set risk, which are acceptable in both models. So in the very beginning, we were just using scaling factors, but now we are looking at the plan in both models. So this is an example of a sacral chordoma patient that we are treating now, and the prescription with LEM is 4.6 gray RB times 16, but this we are saying should also correspond to 4.2 in MKM. So if you just treat the LEM isodose, what you get is a very nice DVH, but if you recompute, you find out that there are hot and cold spots in the MKM system. And if you modify your beam arrangement and if you use tricks, you can have still the same very nice DVH. It is almost impossible to notice the difference looking at the LEM isodose, but you significantly improve the corresponding MKM isodose. And not only for target coverage, I was telling you also for organs at risk, we have set of constraints, and of course for sacral chordoma, the rectum is the most important critical organ, the one that really gives you the problem in terms of getting coverage and treating the tumor. And both LEM and MKM constraints must be respected at the same time. So here you see a case of sacral chordoma. And if you look at this LEM plan, it looks very nice, very homogeneous. There is no hot spot, there is no cold spot, and it is done with 3 beams. But there is more than catches the eye at first sight, because this is done with different beam set, and 3 beam set do not have hot spot, but 1 out of 4 beam set is giving 102% of prescription in the macroscopic tumor. So you see, this is a very nice tool that you can easily do with carbon thanks to the very sharp penumbra. And you see how the GTV is covered not with 100%, but with 102%. What's the purpose of this small trick? The purpose of this small trick is that in this way, the corresponding MKM isodose improves. So we can have 100% coverage without hotspots in LEM, but we can have also the GTV, which is covered by the 98 of the rescaled NKM isodose. So the LEM DVH is always nice. There are a lot of plants that deliver a very nice LEM DVH, but we are trying to have also not unacceptable cold and hot spots in the alternative system. And I think this is a somewhat peculiarity of our center, this attention to both the RB systems together. And for organs at risk, also, I was telling you, we are always looking at the dose distribution. Here you see in LEM, the red isodose must not go into the rectum, and in MKM, the yellow isodose must not go into the rectum. So we check that both systems are acceptable. Now, if you do that, somehow you are a little bit protecting yourself also in terms of LET, but not entirely. Here you see this plan that I've shown you, which is nice in both LEM and MKM, but still the high LET is outside of the target. The difference is that by making sure that also that the MKM isodose is well covered, what we could achieve was to avoid really cold spot of LET in the GTV. So the GTV is basically always covered by the 35 and in some part by the 30 keV per micron, which might have a positive impact on outcome, but in terms of LET, there is so much more to do. So what we are doing at the moment is what I've shown you, and what we want to do in the near future is finally have LET painting for these tumors, both for head and neck and for carbon ion, and there is a lot of possibility. We know that large tumors have worse prognosis with carbon ion than small tumor. We suspect that the big component of that is because large tumors do not get enough high LET, and we know that we could really massively change the LET distribution, even compromising very little or not at all in terms of overall RB weighted dose coverage for this plan. So this is what we hope to really initiate in the clinics before the end of this year, and to have this LET painting in the beginning for part of the treatment, and then possibly for the entire treatment in these patients. Now, the other reasoning for which sometimes we could use carbon is the sharper lateral penumbra. This is a case that we are now considering for re-irradiation of a high-risk prostate cancer with a local recurrence with PET positivity in both lobes.
Are you still there, Piero? It seems that the connection is lost. Can you hear us? Maybe someone else online? Are we still online or is the connection lost in general? So we wait for a few moments whether he's able to reconnect. Maybe already some comments or discussions in the audience. It was a really nice overview, although he doesn't hear it now, about carbon ions, about the possibility, especially the last point, the sparing of the sacral nerves with the precision he showed. And usually he shows also that this is not only a static thing, but over the treatment. Are you back online, Piero? All right, the connection.
I don't know.
So the connection was lost. I was just wrapping up. Would you like to make some final comments?
Yes. Final comments is we are using carbon mostly for adults, and pediatrics. We are only using carbon for very specific situation, that is a bulky osteosarcoma or otherwise aggressive sarcoma, because the focus of pediatrics is toxicity reduction. In these cases, mostly we are reproducing your schema, so the Oscar style approach of only carbon boost, but in very selected case of young adults, we are also doing full carbon. And I'm sorry, I don't know when you were disconnected. I hope you could hear at least part of it.
Thank you so much, Piero. Thank you. Any comments or questions from the audience to Piero? Who is continuing his ride. Then safe journey, Piero, and thank you very much.
Just one more minute, please.
Yeah, here closes the session in this room, but I just wanted to remind you that in the main auditorium, Professor Roberto Orecchia and Arnold Campos are giving a presentation in the framework of the Aristotle Medical Forum in the session of the role of artificial intelligence in radiation therapy. So I encourage you to just step in the main auditorium. Thank you very much.